should be able to. Tiffany, let me know if you can. Just as a reminder, for those who are just joining, we are recording this on the CT and streaming on the CTVSS YouTube channel.
Great. Oh. Thanks everyone for joining. I think we have a pretty packed agenda today, so want to make sure we can dive right in. DSS team, anyone want to offer any other opening remarks before we launch?
Just or Guy, go ahead.
I was just gonna say no. Go for it, Brad, please.
Yeah, no, same as nothing. It just I always want to remind everyone we are really grateful for your continued engagement and participation. I know we say every time, we really do mean it. You guys have, those who are participating have continued to engage, provide us feedback, and help refine this, and we continue to appreciate and we'll continue to need your help. So I know I say it probably sound like a broken record, but we really, really do appreciate it, and we continue to need your help and support as we do this.
Great. So we could go to the next slide. So we've been lots of places with this group, and we are getting close to having a final bundle design that we can package up and review together next month. Today, we're going to focus on the quality metrics, the quality payment methodology, and a handful of outstanding policy questions, many of which this group had previously raised for us to consider and take back. So I wanted to come back to you today with that. Next slide. So first, we'll dive into the quality measures and methodology. And as part of that, we'll talk about the encounter form that we'll need to collect data in order to actually measure some of the quality measures that are proposed. And then our colleagues at Optimus will talk through the prospective payment component and the multiple birth questions and some attribution rule follow-ups that have come out of previous discussions of this group. So just a reminder on how we got to where we are right now on quality and what this group has talked about in terms of quality measures previously. We, at the very beginning of this process, talked about key measures that would look at the overall success of the program. Those included things like reduced C-section rates, reductions in NICU utilization, reductions in adverse maternal events, and measures that we would look at both in aggregate across the whole population, as well as stratify by race and ethnicity and language to keep that equity lens very close on this program. In addition, the quality measures will be measures that are used for measuring provider-specific performance on this program. And so you'll see some of them will align with the overall measures of success for the program as a whole, but some of those measures don't translate as well to measuring at the individual provider level. And there are measures that are not part of the overall success package that we previously talked about that will be additive to this list. In looking at the quality measures and assessing where to start in year one, we also made sure that we considered how they align with other state initiatives and quality measure sets. We wanted to make sure that we were focusing providers on measures that will truly move the needle on reductions in maternal health disparities. looking at utilizing key services within the bundle, and those include doula services and breastfeeding that this group has talked a lot about. And we also, especially in considering what we could do for year one versus a second phase of updating the program, looked at the feasibility of collection and reporting. Just like the overall measures of success for the program, DSS will aim to stratify the performance by race, ethnicity, and language wherever possible at the individual practice and provider level. And DSS also will aim to update these measures over time, sort of phase out measures that no longer make sense, phase in measures that that are important priorities but not yet feasible for year one. So let me turn it to Brad to talk through the measures themselves.
Great, and none of these should really be shocking. I'm going to kind of relatively go quickly-ish through them since we have spent some time on them previously, but we've rearranged a little bit about which ones are paid for performance versus pay for reporting. And so if you look at the left-hand side, you'll see the quality measure. You also see the pay for performance versus pay for reporting. So the first five, we are planning on making pay for performance. That's maternal adverse events, C-section, proportion of C-section among NTSV deliveries, low birth weight, prenatal care, and postpartum care. The reason for some slight modifications is mostly so that we can make sure we have the data available for us. So if you'll see the description and then the measure source. And we really, as much as possible, try to use existing measures that have been validated and certified either through NQF or NCQA designation, and also make sure that we can have available data. So there's obviously challenges with DSS and working with our partner CHN to collect hybrid data. And by hybrid data, I mean data that's coming from claims and also that needs to be extracted from the chart for many reasons that can be really, really challenging to do, especially as we're talking about data at a individual provider level that may only have 30 or 40 deliveries. So we really landed at a place where we're trying to mostly focus on data that we can get through claims at this time, and especially for those pay for performance measures. Moving down to the pay for reporting, obviously we've extremely heavily emphasized the inclusion of doulas and additional breastfeeding support as part of this. However, for quality measure purposes, there are not great quality measures, especially for doula utilization. There are some for breastfeeding that you'll see there is an NQF endorsed measure. But in terms of collecting this data, we are trying to figure that out still in terms of the best way to do that. And so we've been working with Yale Core, who many of you have heard from previously, that helped us shape this, and also thinking about what an encounter form looks like. And an encounter form, for those unfamiliar, we use this in our existing OB P4P program, where we have providers submit data to us through a portal to tell us about various questions that we might have. And so in this case, using Yale Core is helping us think through which questions would be useful, what data points would be useful to have providers submit on doula utilization and breastfeeding support, as well as behavioral risk assessment. So that would be data collected not through claims data, but through an encounter form. Again, that would be submitted on for each member for from a provider's office. And then the two I first mentioned, dual utilization, breastfeeding, obviously very important. And then we are also going to be collecting this through behavioral risk assessments, which includes screening for depression, alcohol, tobacco use, other substance uses, and intimate partner violence. We actually looked at data to see if this is currently being documented, since this is an NQF measure, but it's not really well documented. There's some challenges with doing it. And so we are also planning on collecting this through an encounter form and really trying to establish a baseline so we can figure out how to better measure and capture this data over time. I'm going to wrap up there because we have a lot to talk about today. Happy to get more into the details, but I really wanted to highlight what we just went over now, and we can take questions as they come up on it. Again, 5 pay for reporting and 5 pay for performance. We'll talk about, I'll pass it back to the Faulkner team momentarily to walk through how we're going to be thinking about the program and how these different components of the pay for reporting and pay for performance actually lead to payment. And also, I think we may actually next talk about the encounter form and when we're going to think about collecting that data, I think on the next slide.
Thanks, Brad. So as Brad just described, for the encounter form, in order to operationalize the pay for reporting measures, looking at collecting data at 2 points in the life cycle of the program, during the pregnancy phase to capture data on prenatal care and behavioral health screening, and then also postpartum to capture information about postpartum care, behavioral health screening again, breastfeeding, and doula services. Wanted to pause here and just solicit any additional feedback from this group on the use of the encounter form to inform the quality measures, and also this concept of making sure that information is submitted twice during the program versus just at the end.
And Angela, I'll just add that per the discussion at the provider group, there are practices that have the capability and the capacity to mine this data from their EMR. And so CHN can also accept this as a file at any point that the practice wishes to submit it.
And the other thing I'll just remind folks, and I know it's sometimes hard to track all of this, our quality program, fits within the context of how we're planning on paying and monitoring. So, we've just been discussing having a prospective payment for providers upfront, and then having shared savings as part of our retrospective reconciliation in the back end. This quality design program will impact those payments in the back end to make sure that providers are providing, those that are providing high quality services will be the ones who are eligible for more shared savings, because obviously both of those things are really important to improve quality and reduce unnecessary costs for us.
Yeah, absolutely. And welcome Amy to jump in. Before you do, just also flagging the note in the corner that there is this form that exists today, as folks have been describing, that is used for the OBP for P. And the idea is that the questions on that form as they currently exist will be sunset and replaced by new questions to address these focus areas of quality. Amy, please.
Yeah, I'm thinking about opportunities to gather some of this data from the doulas. I think in particular, the postpartum data and the utilization of the doula could be done that way as well. So I just want to make sure as we're designing that, like, if the screening or like the behavioral health screening is another one, if that were done by a doula or a community health worker, could that be, satisfy the requirement? I'm assuming yes, but I just want to make sure. And then also, it sounds like there are alternative ways than like just typing into the fields of this form to get the data to you. But if a practice like regularly captures that data through like a postpartum touch point with a doula that they've integrated with their practice or something like that, and the doula is using their doula software to gather that data, could they submit it that way?
And just to clarify, are you saying the doula would submit that, or you're just the
doula, or what the doula would be, the doula's like interaction with the patient would be the source of that data, I guess, and that if we could skip the step of somebody having to type it into a form, theoretically, if we could operationalize that.
Yeah, it's obviously the encounter form can be not as efficient as just pulling claims or other data. And I think that's kind of Larry was just saying that for some practices, and that we understand that on all practices we be able to do this, is that they can extract it directly from their EMR, including potentially doula utilization and encounter data, obviously in a somewhat standardized format, but that seems, we want to be responsive as much as we can to allow that flexibility. I think we would be looking for the provider, since there will be the accountable ones to be the ones submitting that, because that's who ultimately that data will roll up to. And I think it'd be hard for us to operationalize, and Larry, I'll have you jump in, but having the non-accountable providers submitting it, if that makes sense. But back to your other question about like if a CHW or doula asks some of these questions, would that count? I don't see why it wouldn't. I mean, this happens all the time in practice with depression screening and medical assistance and other things. We're just looking for it to be assessed and for interventions to be done. And if a doula or a CHW is in the best position from the provider's perspective to do that, then that I think makes sense. Obviously, we want to provide some guidance, but we also want to provide some flexibility around how some of these services are delivered and questions are being asked, if that makes sense.
Yeah.
Larry, do you want anything on the encounter form component?
So I think, our experience with the OBP for P has been that it is practice support staff that enter it currently, not actual providers. We don't dictate who enters it. I think if the scope of that were to expand to folks outside of that, like to include doulas, that's probably entirely up to the practice, knowing that the providers in that practice are going to be, ranked or reimbursed based on the data that they submit. So it'd probably be up to the practice to monitor that data entry component.
That's great.
All right. So folks have additional thoughts about the encounter form as we keep going. Don't hesitate to chime in. Then the next few slides that we'll talk through are now trying to figure out if those are the measures, the quality measures that we're going to use, at least in year one of the program. How do we translate those measures into a quantitative score and then connect that score to payment? So you'll see lots of numbers on the page, but at the most macro level, that is the goal of what we're trying to do with the next few slides. So first, we're going to look at when we calculate the total score across. Let me rephrase. So we're going to calculate an individual score for each of the measures on the measure slate. When we then aggregate those scores to create a single total quality score for a practice, we're proposing that some measures will be weighted more heavily than others. So because of the way in which maternal adverse events and C-section births tie directly to the overall success of the program and have the most impact on sort of the overall maternal health measures that we're assessing, we're proposing that those two measures be weighted the most, that the pay for reporting measures be weighted the least, and that the three other pay for performance measures, postpartum care, prenatal care, and low birth weight, be weighted in the middle of those. So if you look at the table on the right, that you'll see that what that means practically is that 70% of your total quality score would be related to the pay for performance measures, and 30% of the total quality score would be related to pay for reporting measures. And then when you look at the pay for performance measures, half of that score would be tied to maternal adverse events and C-section births, or 35%, and the other half would be tied to the postpartum care, prenatal care, and low birth weight. Before I keep going, let me just pause and see if anyone has comments on the proposed weighting structure to get to a composite quality score.
I do. Sorry for just jumping in. I'm still, and maybe I just need to go back and look, but I'm still confused by maternal adverse events, because just in my experience in other projects, there's so much variation in how different practices are able to access the data that make up those, even if it's claims data and also even if it's clinical data. So I just want to make sure before we give it the highest weight that we are confident that that's something that can be reported, because I've truly not really seen examples of that being able to be consistently reported.
You mean, and just to be, I mean, you're saying recorded in terms of like it's not being entered in, or they just can't, or providers can't tell?
Just there's like tons of variation in how different measures of severe maternal morbidity. In another project, we're working with like 7 hospitals and they're like all kind of reporting it differently. Their data are like impossible to measure against each other, even though they all say they're following like the CDC guidelines, or, most of them say they're following either the CDC or the ACOG guidelines of how to calculate it. I don't know. I see Dr. Morawski's hand up. Maybe he has insights.
And I was going to say, we do have some of our Yale core team members on. I think Valerie, who's been helping lead it, might be able to be the best to comment and have the most expertise to weigh in. And Valerie, would you be able to take that or comment?
Sure. Thank you. This is based off of a newly developed a maternal adverse event measure that takes into account mostly ICD-10 codes, as well as indicators for present on admission. So it takes into account whether the outcome was not present on admission to be an outcome, and then also using the POA codes to require that any of the risk factors were in fact present on admission.
Has that been validated? Like
it has been validated, yes. So it's a new measure. It's going through NQF approval right now. It is based. It does have a basis in the CDC 22 types of maternal morbidity, and includes maternal mortality during the delivery hospitalization as well.
What about blood transfusion? Because that's one area where the hospitals seem to be doing it differently, whether they're counting it by unit of blood or by any amount of blood.
So this measure actually has 2 different versions of the outcome. One includes transfusion as as a maternal morbidity, and the other version of the outcome is all maternal morbidity, excluding those that qualify by transfusion only. So we are this measure is definitely, and we are definitely aware of the ongoing discussions of whether transfusion should be counted as a maternal morbidity, and this measure would allow us to look at it either way.
Okay.
And if you, I think we have more details on it. Amy, if that's helpful, happy to share. If you want to, feel free to ping offline if that's helpful to follow up and get you more information, because I think you might be curious regardless.
Yeah, and if it's a better measure, I might want to use it in my other project too. So yeah, I'll follow up. Thanks.
Dr. Morawski?
This is a conversation I think people have heard many different ways, at least in terms of cesarean section, but I would like to focus on the maternal adverse events. And since we're having a discussion of waiting, I'm just wondering how hospitals with the most critical services, ICUs, blood banks, ability to do transplant surgery, neurosurgeons, things like that, and the high level NICUs are going to avoid being penalized for providing services that have higher probability of maternal adverse events because patients with these critical illnesses are being sent to these hospitals.
In this case, since we're holding the outpatient provider accountable for this, it wouldn't necessarily be held against the hospital. Obviously, we would know where folks are going, but really this pertains to the outpatient provider ability. Obviously we're monitoring for quality, and then it will impact their ability to receive any shared savings as part of this, if that makes sense.
It does, and that's going to create an interesting communication, which our state's been in need of, our high-level hospitals providing information back to referring providers in the community in order to accomplish that. Is that right?
Well, I think you're right that some of this, I think there's two pieces to this. One is, you're right, they're probably, I hope this will increase some communication that will incentivize that. We won't necessarily be mandating that, but I imagine as a provider, you're probably going to want more information from maybe what's happening than previously was provided. Obviously, some probably hospitals are better at this, and some outpatient providers are better at this already. And then we are working to make sure that we're going to be providing quarterly reporting to providers on how they're doing. And so there's a couple components. There's one is the retrospective reconciliation component, where we take the full bundle and the bundles have been done, and we say how you did against a price, that's been set and adjusted. And then there's also like, how are you doing on these quality measures? And so usually a lot of that data doesn't happen until the end. And we've definitely heard from providers in other programs, such as like PCMH Plus, that often you don't know how you've done in the program until the very end of it, which can take a long time. So we're hoping to provide this data, at least data that we can, reasonable data that we can. We're still working on some of the details on a more frequent basis, so that as a provider, you're getting it more like, how am I performing, instead of at the end of the bundle, how am I doing quarterly for those that have been finished, those that have been completed in that 3-month period, or, so hopefully those two pieces. One is this will hopefully encourage that linkage more. And then two, you'll be getting, hopefully the plan is to provide more data to providers, to outpatient providers, on their performance on a more regular basis. Does that help answer that question a little bit? And feel free to ask, if I didn't do a good job, feel free to push back or ask for more questions.
No, that was a good response. I'm just trying to think of, say, community folks send a patient over here in preterm labor breach and has to have a cesarean. Well, it would be breach, wouldn't be NTSB, but a complication. And then that patient goes back to our community. The provider that initiated the pregnancy would then be the person who has the maternal adverse event cesarean birth, even though they weren't involved at all in the decision-making or process of delivering the patient?
Yeah, and it actually stems a little bit to one of our further things that Optimus is bringing up in terms of accountability. But yes, so the answer is yes, that would be who the accountable provider is, as long as obviously this isn't someone that's established at the end of the 3rd trimester or something that they're otherwise accountable to that provider. And I think from the DSS and the perspective is like, we want that accountability over time for outpatient providers, and maybe to be more engaged in that process, acknowledging there's challenges with doing that. But yes, that is the plan, as for that attribution to occur. Feel free to provide more commentary if you'd like to.
No, that's helpful. It's just these things are going to happen. I think it'll probably be less of the births as a whole, but it's just in the weight of maternal adverse events.
Yeah, I mean, I think fair to call out. I think we're obviously trying to weigh the things that we think may be most impactful in terms of change over time, if that makes sense. So the things that both maternal adverse events and C-section, we've heard, I think, from this group and from others, that we really want to avoid maternal adverse events. Obviously, some of them are unavoidable, but there are some that can be impacted by changes in prenatal care and other decisions, and that our C-section rate is very, very high, and there seems to be a fair amount of room to bring that down over time, and that's kind of how that somewhat prioritization. But we welcome further feedback on that, and I know Chris, if you want to comment any further, or Mark can jump in next.
Thank you.
So my only comment, Dr. Morawski, is that it's something we're interested in looking at, which is what proportion of births are ultimately delivered today by the hospital doc versus the community physician, and how to think about that from an accountability perspective. How much of the variance in maternal adverse events performance on that measure is a function of what happens in the hospital versus what happened before the hospital. And I'm not expert enough to have an opinion about any of that, but would like to look at it with our birthing hospitals before this process concludes, and of course with DSS. The question I have pertains to prenatal care. I don't recall, that's the standard NQF measure of prenatal care, is that right? I don't recall how it's specified.
Yes, if you want to, Tony, you want to go back to the 2 slides. This one's the NCQA 1017, and you can do a hybrid versus admin. And in this case, we'll do admin.
So
times data.
If you don't begin care with a community OB until late in the 2nd trimester, you're still part of the bundle, is that right?
Yeah, so say you begin in the 2nd trimester, yes, you'd be part of the bundle, but you obviously wouldn't have early prenatal care. I think that kind of what you're alluding to is that you might.
Yeah, I guess given the weight that's given, it would seem to me that it's a disincentive to accept those patients into care, both because out of the gate, you're being, you're going to score poorly on one of the heavily weighted measures. And in addition, you probably have less ability to influence the outcome of that episode, basically, if you're involved so late. And so I guess I wonder whether for 2nd trimester pregnancies, it makes sense to include that measure because an OB has no ability to impact, unless I'm mistaken, and very little ability to impact when somebody gets to them.
Yeah, I think that's a fair point, Mark, that there's obviously concern that how much the providers, whether they're certified nurse midwives or OBGYNs, or I don't think actually have any family medicine practitioners that we've seen would be included, but any of those folks might be challenged to, but obviously we also want to encourage early prenatal care because we know it's extremely important in reducing some of those downstream outcomes. And so it's but I think your point is fair, and we can maybe bring that back internally to see if there's anything you want to consider.
I mean, I guess you could certainly take the perspective that a truly community engaged practice will be using their relationship with their doulas and everybody who's involved in supporting people who can get pregnant to ensure that there is awareness and engagement. In other words, it becomes I could see how it could incentivize a practice to be much more active in promoting early engagement. So
yeah, and that's kind of the goal, but understandably there's a downside, as you kind of highlighted, and I think we can go back and discuss if there is anything we should be considering here. But I appreciate that.
Thanks.
Brad, can I just ask a quick follow-up question of Mark? First of all, Mark, thanks for that comment. That makes a lot of sense. On the first thing that you mentioned, which felt like not a concern with the policy, but can you just say a little bit more about what you meant there? I think you're talking about the percent of the variation kind of being driven by hospitals versus community providers. It sounded important, but I wasn't fully tracking what you were saying.
Yeah, so hospitals are increasingly doing work to promote favorable maternal birth outcomes during the period when they're in the hospital, right? So the AIM bundle is an example of that. There are other bundles that are being looked at where you're really focused on optimizing to the extent you can the care that's being provided in the hospital. And if 30% of the, and this is like, I don't know that this is true, but to give you an example, if a substantial number of births are occurring with an OB that's part of the birthing hospital and not the quarterback provider, the one who's accountable for the episode. One wonders about how the hospital should figure into the overall accountability and even the reward structure, because you want hospitals to be, pulling in the same direction and working collaboratively. It's not to say, so hospitals obviously aren't indifferent to trying to advance maternal health outcomes, but if you're focused on an all-in effort to drive better maternal child health outcomes, then birth outcomes, then it seems to me, if it were 30%, one would want to think carefully about whether how you include hospitals as participants, not bystanders in that process, and the actual payment model. So that's, and it's, and Guy, in bringing it up, it's not something actually that I had awareness of 6 months ago when we started these conversations. Actually, it was a year ago, but has only recently become something that I'm interested in learning more about and also talking with our members about. And it may be just a non-issue. Look, we're working in that, for the deliveries we manage directly through our OBs, we're going to do our part to advance maternal health, and that's fine.
Great, thank you. Very helpful, Mark. And I just want to express our interest. There's obviously the hospital settlement that is the meta context in which we are all operating, but not for the July launch, but for longer term. I want to express enthusiasm and interest. We know the important role that hospitals play in most healthcare, certainly including this, and it certainly would be our interest to include hospitals more directly in this APM, assuming we can do so given the meta context of the hospital settlement. So more to come on that, but thanks for that.
Understood. Thank you.
Thank you. So yeah, so we talked about the measures themselves. We talked about how to weight them in terms of creating a composite quality score. In calculating that composite quality score, what we're really trying to do, or what we're proposing to do, is calculate two different scores. One that would be your overall performance score, or a provider's overall performance score. The second would be the provider's improvement score. So performance is just, how did you do this year? And the improvement is, how did you improve your performance, or how did your performance change this year compared to last year, or your baseline? So for each measure, we would look at a historic baseline, calculate your actual performance in the performance year and create a composite score that a score that reflects it's called normalization, like how to make sure that the scores are comparable on a scale of 0 to 100. And then tally all of those individual scores up to create that composite performance score. And the improvement score then becomes the change in your performance on the pay for performance measures only from the performance year compared to the baseline year. We would then take those two scores and compare them to an earnings table. So you go to the next slide, Tiffany, and then we can talk about both of these in tandem. So in the prior slide, we were looking at somebody who did fairly well and scored an overall 90.1% on performance and improved nearly 30% year over year. So if you were to take that and then look at a tiering where we're saying, if you are a top tier performer, you're going to get 100% of the potential earnings. And if you are a substantial improver, so even if you weren't a top tier performer, but you improved significantly year over year, you would be able to maximally earn 90%. And so what we would be doing is calculating that performance score and that improvement score for every provider, then using those two scores to compare them to a table to say if would you be eligible for 70%, 80%, 90%, or 100% of your total earnings based on performance alone. And if you improved significantly and your improvement score or tier would be higher than your performance tier, then you could earn even more. So if, for example, we've offered 6 different sample scenarios in the green table on the right. So if you look at group 3, that is a practice that didn't perform overall very well on an absolute basis, but made substantial strides in improving year over year. So that practice would earn the 90% improvement instead of the 70% performance. Let me just pause there and see, DSS team, if you want to add anything else about the methodology, and then we can open it up for questions and comments.
Thanks, Angela. I'll just say one quick thing, and obviously there's a lot of detail on this slide, but the policy design that the trade-offs that we were making, we don't want to penalize top performers, like quality incentive structures that basically say, did you do better than last year, inadvertently end up penalizing the very top performers, because regression to the mean, and more generally it's kind of, you have a ratchet effect, and we wanted to avoid that. At the same time, for providers who were not doing so well, if it's sort of hopeless, if there's no path to their getting access to the extra payments, it can kind of dull their incentives to try to do the really hard, important practice transformation that we know is underlying all this. So just the policy rationale behind both is we want to reward top performers, and we also want to give some incentives for all providers to improve. And that's sort of the compromise that we struck here. Obviously, very much welcome your comments and feedback, but I just wanted that overall philosophy statement to be on the table as we discuss this.
And I'll just quick point on it, and sorry, Angela, I missed, there was a brief connection issue I had, but the draft informant here, so we're waiting to have, these may need to be adjusted in terms of the overall performance and improvement just based off of historical data, so we can better toggle this a little bit. So we're waiting on some data to help inform that, but these are kind of the draft ones as of now, waiting for further refinement as we get actual data. And I think I saw someone, Karen, did you have your hand up? I think Karen's hand's up.
Yeah, just a quick question. So I just don't see in here where the risk adjustment is happening. And again, not the quality metrics for which risk adjustment is built into the standard metric, but the risk adjustment based on ADI. Where is that happening?
That's at the price. That's happening in a separate portion to this. So only, and Valerie, I think, is on Meal Core. One of these is clinically risk adjusted. One of the quality measures that impacts this is clinically risk adjusted as part of the quality measure itself. And in a separate meeting, Mark had raised questions about, risk adjustment on specific measures, which we're really, as of this time, not planning on making any adjustments to especially those NQF or NCQA designated measures themselves. But in terms of both clinical and social risk adjustment happening on the price setting that we're using as a price target. And I'll defer to our, I think, Martin and Optimus team if they want to comment further on that.
Yeah, I think only, Brad, to underscore what you said, which is that, and which is to avoid a situation where somebody's practice is predominantly in a high risk area where the opportunity to improve is challenging because of certain social and environmental conditions. And for that reason, I would hope that that's why I wondered whether if you're in a lower tier and it's in part a function of the community that you've elected to serve, whether there could be a higher reward for more incremental advances in quality, which isn't to say, I think one of the things you don't want to do is you don't want to risk adjust out the variance associated with those conditions, because you don't want to neutralize them from a payment perspective. At the same time, it seems to me that one foremost wants to make sure that the practices that are serving some of the most patients who are in some of the most challenging areas are really incentivized to do that work, not only to see those patients, but are duly rewarded for incremental gains in performance.
Yeah, definitely. I think something we'll need to be monitoring, considering to see if certain practices are more impacted than others. Obviously, as Guy, I think it mentions, like both trying to have those who show improvement as well as where they, as well as performance tiers, has, trying to get that balance right. And I just to say, I think we will be obviously need to look at this over time. And Karen had asked in a provider meeting, what is our plan to actually refine this? And I refine our quality program for this. And we haven't laid out exactly how we're planning on doing that, though that is something we're working on clarifying to exactly what our process will be. And then I'll just because Valerie said in the chat, and thank you, Valerie, it's the adverse maternal event measure is the one that's risk adjusted as part of the measure itself.
And I just want to clarify. I was looking to see if you had changed your thinking on process, because I do think this is in line with some best practices or some recommendations that have recently been released on other value-based payment models. But it would be helpful at some point to see how the payment is being calculated using that risk adjustment, just for to have a full picture of how the bundle's going to work. And I'm not sure, that may be later in these slides. I was just trying to understand the complete process and put all the pieces together. So that's, just wanted to be clear.
Thanks, appreciate that. Yeah, we are definitely wanting to kind of put all those pieces together. So it's hopefully everything comes together at the end as we're getting close to that final design, our final design decisions.
Brad and or Martin, but maybe just on Karen's point, it might be helpful. And Karen, we haven't yet done all the analysis to lay out how social risk adjustment works, but maybe Brad or Martin, can you just remind folks just high level, the interaction between the quality benchmarks and the price benchmarks, how those fit together? And Karen, whether or not that was your question, I do think that's something that other folks might benefit from a refresher on.
Sure. So the risk adjustment is intended to adjust for those factors, whether it's health or social determinants of health of the patient that would impact delivery outcomes, so that the provider isn't responsible for those things outside of their control. So the risk adjustment puts a weight with the health factor or the social determinant that is then adjusted on the baseline target price, and then also in the actual outcomes in the performance here. So the idea with that is that the provider is not responsible for those factors, or at least not as responsible as they would be in an unadjusted scenario.
And Martin, when you say it's factored into the outcome, it's really the price outcome, the cost outcome, right? Not the Not
Correct. The price, yes.
So that's an important distinction, but I understand.
Just want to acknowledge, Cynthia, you've had your hand up. Did you want to jump in?
Yeah, maybe I don't have a full understanding of this this tool or the process. I've been lost, like, I don't know, 6 meetings ago. But my question is, when we're talking about performance and how it's being measured, meaning the medical provider's performance, what are the factors that are contributing to that? Is that just based on the birth outcome?
For all the quality measures, sorry, Cindy, I didn't quite catch all of that.
Well, again, I'm probably just, it's just a general question. I guess. Yeah, I'm just trying to figure out, when we're talking about performance, what is that? What quantifies that? I'm not understanding it.
But I can take a stab, and other folks chime in, and Cynthia, you can tell me if you have more questions after this. So when the overall program is driving towards improved maternal outcomes and reduced disparities, to hold providers accountable to those outcomes, the success measures at the individual practice level are a combination of the total cost of the bundle and the quality performance on the bundle. So when Martin and team are talking about how risk adjustment applies and how that factors in, there's a series of calculations to say, at a baseline, this is how much we think practices should be, how much total medical expense should account for a given pregnancy and delivery and postpartum episode compared to what actually occurs. And then we sum that up for all of the patients of a given practice. And that difference gives you sort of a pool that says, okay, practices that did better than than we thought they were going to could earn X number of dollars. We then look at that X number of dollars and say, okay, how did you do clinically from a quality perspective? And to measure that, there would be a quantitative score for performance on 5 clinical measures that we talked about today: the maternal adverse events, the C-section births, the postpartum care, prenatal care, and birth weight. And then a process score that says, did you tell DSS if you your information about breastfeeding, contraception, dual utilization, behavioral health risk assessments, and preterm birth or labor. All of that information then gets rolled up into a quality score and compared against what your baseline quality would have been. Those two numbers are what we're talking about here to say, what was your overall performance and how much did you improve? And then using those two numbers would inform how much practices could then earn from their financial performance on the program. Does that help, or is that your question?
Yeah, and it helps me understand what is being measured. I guess I still don't know how the dual being factored in, but go on, maybe we'll get there.
In the doula piece, I was just going to say, so kind of we first reviewed just high level. Angela, feel free to, I'll take it, you add on anything I get wrong here. So We outlined those measures, including one that's a pay for, specifically pay for reporting, which just means that depending on how you do, we need the data. And a lot of the reason we're trying to figure out like what's a baseline, how do we measure this effectively? And so that goes into this score. It gives you an idea, like basically for pay for reporting for doulas, like was a doula utilized in some fashion? That's the information we're looking for. Eventually, we will, I think, want to hold providers accountable for like how many doulas were utilized for X number of members, or were they present at the birth, or other components to what we hope to see. I don't think we know at this time exactly what that measure should look like. So we're really just gathering information on due utilization at this point and asking providers to report that to us. So as long as you're reporting it, you actually are going to get points for reporting it if you're a provider. That goes into an overarching score in terms of where you're going to fall in terms of the rankings for all of your quality measures that then impacts how much. So we know how much your shared savings could be. There's a set price, and if you come in underneath that and there's a shared savings of $1,000 and you've done relatively well, the highest rank, then you can get a portion of that back as a provider. But you have to have done, that requires you to perform quite well on the quality measures compared to in terms of a tier basis. Does that help at all? And please feel free to clarify anything I just said.
It does. It does.
And thanks for helping clarify, because I know this can get very confusing. We are very much in the details and the weeds, so to speak, of this. And I know if you miss one meeting, you can say, what's going on here? So we welcome those types of questions. So if things aren't clear, if you need more information, please feel free to jump in. And just to say, just as a reminder of the overarching, we're planning on paying providers prospectively amount of dollars that they'll be getting during the prenatal and even the postnatal period that accounts for those specific bundle of services based on historical use. So we'll be getting payments. And then we're going to be at the end of the postpartum period doing this reconciliation where we take costs from delivery, other things, and kind of say, how did you do compared to a price set point that's been made? And then after we do that, we'll see, did you come in underneath that or above it? And then depending on if you're underneath it in the first year, you're eligible for shared savings potentially. Obviously, there's some details there we'll have to clarify on. And then depending on your quality score, that will then impact what portion of the shared savings you actually get. So that's kind of the summary statement. And Martin and Angela, Guy, feel free to modify, but that's kind of the very higher overarching view of it. And that the doula piece fits into the quality measure component in terms of how we're measuring that.
And Cynthia, you asked the question when I was saying, hey, let's give an overview of how it all works. That's exactly what I had in mind. So thanks for prompting us to do that.
Okay. So I think that's actually a good segue and hand it over to Martin to talk through some of the next concepts.
Sure. Thanks, Angela. So now to take a look at the draft prospective payment amount. This will be paid during the prenatal and postpartum periods. The payments are based on each provider's historically provided services during those periods, and it excludes the delivery costs. So this would be a monthly payment, and the draft range that we have for that has an average of $149. And it's between $57 and $195. That's the 5th percentile to the 95th percentile. The variation in that really is due to the historically provided services. Some providers provide a lot of prenatal services. That includes things like labs and ultrasounds in their office. And so they're in the higher end of that range, and then some don't provide as much, and they're at the lower end of that range. An additional $21 per month will be included, and that is a draft amount that will be included for breastfeeding support and doulas. And DSS is still determining how to handle the doula and breastfeeding payments during the retrospective reconciliation. So how they would be handled in comparison to the target price and so forth. And these numbers are drafted and are subject to change. So just keep that in mind that these are not the final payment amounts. I'm just going to pause there to see if there are any questions.
Can you remind the number of months of postpartum PMPM payments there will be?
That's 3 months, 90 days.
And then what's the assumed number of prenatal for term on average or for term pregnancies?
So we the earliest the prospective payment can start is the second trimester. So for this draft look, we looked at 6 months prenatal. That might change a little bit in the final, but we said it's at really the maximum for that. So the denominator for the time period is the maximum amount. So the payment itself would that is conservative on the payment amount. So the final might be a little bit higher because of that.
Okay, thanks.
Karen, you have a hand up?
I'm just wondering if there's any rate guidance for providers, because obviously I don't think you're making the assumption that they're going to be able to hire doulas or breastfeeding support for a total of $120. So is there some effort to help providers find a reasonable rate? And is there an assumption that the rest of the funding for those wraparound supports is coming from the anticipated savings?
So just a quick thing, great question on this is that this is kind of estimated to be across all deliveries as of now, or all pregnancies. And we recognize that especially early on, one, there's not enough doulas to actually serve every member. And then two, this is going to take a little while to actually get off the ground. And so we have a, kind of limited pool of dollars. And just to be clear, it's, there's no surprise here. It's like we have $2.5 million for both breastfeeding, lactation supports in that in the first year that we're distributing. But we're still determining how on the back end. So say someone doesn't utilize a doula on the retrospective reconciliation component. So on the back end, we actually may thinking about repurposing some of those dollars and removing them from folks who for whatever reason, whether they didn't have a doula that was part of the practice as of yet, or just because the person who's delivering doesn't want a doula, how to take those dollars and then potentially likely redistribute those to providers who did utilize a doula as part of a birth, if that makes sense. So basically we are upfront distributing it equally, but on the back end we'll likely redo this. And then I'll pass it actually to Amy Romano, because PMC is contracted with DSS to help us think about a few things, including some of the contracting issues and a few other aspects that that's underway for some of this work. But just to also acknowledge one piece, one other thing is that we're not being specific about how those retrospective reconciliation, like if there's shared savings, how that would be utilized. So would that be actually shared with doulas or other breastfeeding support staff? We have not been explicit. I know you kind of, I think, asked that, Karen. So just to say we have not actually said that, but that doesn't seem like an unreasonable approach. Again, we want to provide some flexibility with how providers operate in this environment. And so we want to give direction and be prescriptive when necessary, but also provide some flexibility when reasonable.
Yeah, and Karen is from Health Equity Solutions, and they're working with us. So we're both working on this issue. And I think we have had some of these questions. We've answered some of the questions that we've had and that we were working on earlier this morning. But I think as this information percolates out, it's really challenging to see that 21 times 9 is the budgeted amount for doulas and lactation when we're saying that everybody deserves that. And so I do think we have to start to get more explicit about what the assumed rate of utilization will be and how we're going to get to a rate of, adequate payment for doulas and, be, in the ballpark or at the vanguard of what we're seeing in other states that have, been more successful with this. So we're thinking a lot about those issues. We are talking to providers and doulas and Medicaid and Husky members throughout the state. We've done some focus groups and surveys with those. And so we're looking at a lot of data right now. And we understand the operational challenges for practices in like adding a doula, especially if this is, the economics of it, adding the infrastructure to actually employ doulas. And even if it was easy to do that, there are a lot of reasons that we're hearing from doulas and Medicaid members why that's not their preference either. So we are trying to think like really innovatively about how we can work around these structural issues, probably with some kind of third-party solution that practices can plug into, and that doulas can have more agency and portability, if you will, of being able to follow the patient if the patient changes course or needs to switch practices, for instance. So I'm sure people have a lot of questions about this and we're actively talking to folks. So if anybody wants to like take a deep dive on these issues with me or my team, we're happy to set up those calls.
And then the only thing, Ski here, thanks for the question. I think it's totally, I think we can share the assumptions on take up that underlies these figures. We don't have those, I don't think, teed up on this slide deck, but I think we certainly can. And I think it's a fair push. And ultimately, this will partly be a question of budget and money and things like that. But I think for right now, maybe our next meeting or next time it's appropriate, we can walk through those assumptions.
Yeah, I think the assumptions would be helpful. Thank you. And thank you for walking me through that. I just would add this to the list of things that I would want to know what the plan is for regularly updating, because hopefully uptake will increase and doula availability will increase over the years. So there would need to be then a plan for revisiting those assumptions and how they influence the way the funding is calculated.
Mark, you have your hand up?
Yeah, my question was my question was really related to what Amy Romano was describing about figuring out a creative way to accommodate a patient's wish to, presumably, Amy, to choose who their doula is and then for that doula to stay with them. And so that's different than how a practice ordinarily manages its care team, where they hire med techs and medical assistants or whatnot, and they take all responsibility for them. So I would be certainly interested in hearing more about how you're thinking about that, because the money is flowing in such a way as they're essentially either a contractor or an employee of the practice. It seems to me that fee-for-service is a problem when it comes to controlling growth and healthcare cost, but fee-for-service is a great way to induce the growth in supply. And in the near term, what I'm hearing is that the supply of doulas is the thing we need to cultivate, qualified doulas who can provide the kind of support that's envisioned. And so I think a reconciliation process, or frankly, if you had a sort of 2-year period where up to a limit, there was even fee-for-service billing for doulas, through the practice or something like that, it would allow for a more flexibility and sort of immediate responsivity to practices that are able to solve for doula access in the near term. Reconciliation, I guess, could do that as well. But it does seem to me that if you have dual practices that are ahead of the curve and those that are behind, the 2.5 million you have available should be made to support those who are really innovating in this essential space. Last question I have is, if I'm not mistaken, with the PCMH Plus program, the $4.50 PMPM that FQHCs get is netted out of the savings return, or is that not the case? And if it is the case, do you envision that the doula and breastfeeding will be netted out of the savings calculation, or is it basically new coverage that is not, for which a provider isn't penalized from a shared savings perspective?
I think that we kind of back to that bullet, Mark, great question about whether it's providers being held accountable for the additional dollars or not as part of the shared savings. I think this is part of one of the questions we have yet to answer on that. And if we're including that as part of it officially, it's a very reasonable question. And I think the other thing you asked is the fee-for-service component of doulas. And the real reason is, I think most of you are aware, is that in this process is with DPH is the licensure component for doulas, which is underway. And I know this has come up, and I think we will need to revisit doula coverage in the future as part of this program and how we're doing it. And if it's working, I don't think there's any reason we shouldn't be doing that, and how we're actually reimbursing providers from it. Sorry, thank you. Certification, not licensure. I appreciate the clarification. My mistake, and thank you, Cynthia, for that. So what we will be, obviously the opportunity to do that will be in the future post-launch on that basis. And how do we think about, how do we think about enrolling potentially doulas and or providers, and do we revisit this? And I think it definitely needs to be on the table for us. We, at the end of the day, we want a program that works and is actually achieving the goals. And if for whatever reasons the program is not, then we should be very open to revisiting how we're operationalizing it. And I think for practical purposes, we kind of landed on this because of the process underway with DPH, where which now will be wrapping up, and there will be certification for doulas. That wasn't the case as we were initially designing this, and that created some challenges. And this is kind of our operational workaround, which I think there is possibly benefits to, but obviously there's also challenges with. So just acknowledging that it's, we may have thought about this differently if we were going about it again in a different environment.
I'll just add that, someone needs to make a fee schedule, and like at the end of the day, doulas will get paid fees based on what they do. And so we're thinking, we understand that this, why it's not set up that way for the reasons that Brad just described, but another challenge of putting it to the providers is then you've got all of the different providers around the state trying to figure out, how much is a visit worth? Well, what if it was a telehealth visit? How much is the birth worth? What happens if it goes on for 3 days? Those kinds of questions. And even the largest, practice group in the state was like, we don't want to be involved in like adjudicating those kinds of questions. And that seems like a lot of work. So we hope that we can put some infrastructure and ideas in place that we can at least get some feedback on, so that when doula certification comes online and there is a mechanism for fee for service, we've hopefully been able to, work out some of those kinks and thought processes. But I'm looking forward to sharing more about sort of what are some of the solutions that we envision. But I do feel like it's solvable if we can create essentially like a central platform that doulas can that can manage the sort of certification or, whatever will be put in place for that side of it as well, because this structure also makes the provider responsible for deciding who's the doula, what is their training and qualifications need to be. So we're trying to line up as closely as we can with what we anticipate the answers to those questions will be with the fee for, with the certification legislation. And to inform that with what we're learning from other states and everything. But there are some interesting models where doulas, either as a collective and kind of cooperatively, or with kind of like innovative kind of tech partners, have creative platforms where people can find doulas, you know, that are speak the language they speak, have the cultural background they're looking for, you know, have the, you know, whatever the thing is that people are looking for, and really match with a doula who's going to be a good fit for them for this relationship-based care that we're trying to put in place. And then for the doulas to be able to handle all of their kind of like credentialing essentially and claim submission, they have no interest in like, you know, building a whole claim submission side hustle. So they want that part to be easy as well. And, you know, and then the provider, what would be different here is that rather than these central, you know, spokes contracting with an MCO or, you know, a health plan, and as they do in other states, they're essentially would be contracting with the providers, and then we have to figure out a way for the payment flow to work on that side. So there's a bunch of stuff to still figure out, but that's kind of where we're headed in terms of what feels like possibly like the only workable solution, or to have a really like pilot minded, well, you know, like I think there are probably a couple practices that might go ahead and put this in place for their practice. But we honestly haven't found a huge appetite for that here in Connecticut.
I just wanted to say, Amy, thank you for that, because you will be presenting to this group your findings at some point in time, you know, when you've done quite a little bit of this work and you're ready to present. So we can talk about that behind the scenes as well, but thank you.
All right, if there aren't any other questions or comments on this, we can take a look at the next slide. This is an update on multiple births. I think we had shown some numbers previously on this, but this is updated from where that was. The first point is that multiple births make up about 2.2% of deliveries. Multiple births are more costly than singleton births, about 1.7 times more costly. Multiple births are being considered for inclusion in the prospective payment. As noted previously, DSS is still determining how to handle the doula and breastfeeding payments during the retrospective reconciliation. But for multiple births in the reconciliation, multiple births would be excluded from the target price and effectively paid at fee-for-service rates. So we just wanted to put this in front of you all to see if there were any concerns about including multiple births, especially when it comes to providers possibly incurring some greater costs than average that wouldn't be compensated until the retrospective reconciliation. And I think the consensus that we had been hearing was that it's preferable to include them, even if the payments might come at a later point. Just having them in with the prospective payment is better than not.
And just to highlight that, you know, obviously you heard a lot of comments from, I think, from this group that very important to make sure that folks are getting access to the same resources as much as possible. And so that's really the, really trying to be responsive and acknowledge that this is an important small population, but an important population that we try to get those resources to.
Okay, if there aren't any other questions or comments, we can take a look at the attribution rules. I think we've already discussed this one today. This is just a clarification from maybe things we had said previously, but this is just looking at pregnancies for maternity providers that provide care during the prenatal period, but do not perform the delivery. They are planned for inclusion. This is just to make sure that the program has a broad reach as reasonably possible, and allows for attribution for providers that do not perform those deliveries. Then we had a couple discussion questions here. Just is providing prenatal care sufficient to warrant shared costs and savings? And are there any other concerns with inclusion of these providers? And I think we had already discussed this a little bit earlier. So any further questions or comments would be welcome here. And this is our final slide with content. So we can open it up more generally for questions or comments now, as we have about 10 minutes left.
I'll just pipe in that I think it is sufficient. Providing prenatal care only is sufficient. I think there's a lot of opportunity in the prenatal care timeframe to impact these outcomes. And it's also really increasingly common, I think less so in Connecticut, but this is where a lot of places are going, especially as we deal with some of the workforce challenges. So it would probably increasingly exclude practices as we sort of deal with that those workforce issues here.
Okay, thank you for that comment.
Would they have to also provide postpartum care in order? I think most of them that provide prenatal care also do the postpartum care, but I would want that to be, I guess, one of the requirements.
Okay, that isn't, so the way the attribution is structured, that isn't necessarily a requirement, but I think that is our understanding of what was expected. Brad, do you want to comment further on that, or someone from DSS?
Yeah, I mean, I would just agree that would be an expectation. It's obviously also one of the quality measures that people will be held accountable to, that is prenatal care and postpartum care, and those go hand in hand.
Yeah, maybe Amy, I'm not a clinician, by the way. So let me share a non-clinician thought just for your for the group's discussion. I wouldn't want to have a rule that said if a clinician provided prenatal care but not postnatal care, she's out of the bundle. And the reason that I wouldn't want to do that is I want to encourage our prenatal care providers to either provide postnatal care themselves or ensure that their patients get that postnatal care. And if there's a backdoor saying, like, if you don't do the thing that we all want you to be doing, then you're out of the bundle, I think that would create kind of funny incentives. So I don't think it makes sense to exclude providers who just do prenatal and not postnatal. But as Brad's saying, I think the reason for having it be a part of the quality measures is to encourage or incentivize that provider to either do it herself or to ensure the patients get that care.
Yeah, it might be a non-issue. I'm not sure anybody's out there just doing prenatal care.
Can I ask a question? I think some of this is a refresher reminder, and some of this is an actual question. So in terms of the rollout of this, and then the QI process of how we learn after it's rolled out. So the first part is this being rolled out, again, is this being rolled out in stages where reimbursement is less tied into, so people can kind of jump into this and get a feel for process? And then the second question is, how are we, do we have a plan currently for the QI part of this after the first year, specifically looking at like tiers and the doula lactation issues specifically? How are we going to go? Do we have a plan currently for how we are going to learn from the first year?
Great question. And so in terms of payment, it just says, and just again, I'll just highlight it. So the prospective payment is based off of historical utilization patterns. So expect that to be, again, kind of what providers are fairly accustomed to, obviously in a slightly different mechanism that they're getting reimbursed. In that prenatal period, also in the postpartum period, the quality program tied to shared savings in the first year is upside only, meaning that you can only generate shared savings. So if you generate shared savings and there's actually reduction in cost, as well as high quality, you could receive something. However, the cost is higher than expected. There's no opportunity to lose resources, which again, we're trying to ease in providers. So I think that is part of this. We're all launching this, we're getting this off the ground, getting people comfortable with it, with a plan of moving to phasing in downside risk, where you potentially could actually lose money as a provider by having, on aggregate, costing more than the set price. But I also will mention, we haven't been explicit about how the quality program will impact that in terms of downside risks. So just to know, we didn't call that out today. And that does need to be addressed. Now, in terms of the actual, like, how are we going to monitor and improve this program, which I think is a great question, and actually pertains to something that Karen Siegel had asked before about, like, how are we going to update our quality measures? Well, how are we updating the program? We haven't actually outlined that very clearly at this point. We will want to have ongoing engagement with providers. We will want to be presenting the data in terms of how this program is going, both with provider forums, but also out to places like MAPOC. We'll be interested to see how this is going. And so we will need to map out a fairly clear plan and also time frame for that, which we have not done. So I can say we are very committed to doing that. We just have not done that yet. We're, I think, needing to wrap up kind of our first year plan here, but we need a plan for what in the decision-making process for year 2 and on. So I think great point, and thank you for highlighting that, Chris. I'll just add, I think our goal is to continue to have engagement with folks like yourselves to help inform this and provide feedback to DSS, just as you've been doing today. I think obviously it's very clear there's a lot of aspects of this that we're going to launch and need to revisit, and that's going to be a really important part, that we can't just launch it and say, we're done, everything's great, because I think recognizing that there needs to be improvement is part of hopefully what we've been saying all along, but also clear that we actually are committed to it, as we have been hopefully committed to taking your feedback through this process.
I have one other point or question about the attribution, and I think it's not so much this, the prenatal care, but for the birth, I want to make sure that we're explicitly paying attention to the situation where somebody gets midwifery care during labor but needs a C-section, and where that C-section might be done by a provider from another practice, which is very common that happens. And there are some practices where it will always happen when there's a C-section. There's some midwifery practices that are independent because that's how we're licensed here. So I just want to make sure we're not setting up a situation where the midwives are not going to get paid anything for labor care and E&M services during the birth.
Those payments are unchanged. So like delivery services are still being paid in a fee-for-service manner.
Oh, right. Okay. I was thinking it was a bundle. It was another component of the bundle, but it's just the fee-for-service.
It's accounted for in the, so we are, it doesn't account necessarily for the prospective payment for the delivery piece that's happening. So hospitals will bill, those providers will bill fee-for-service. That does get accounted for in the retrospective at the end, but it wouldn't necessarily change how that billing practice is occurring during the delivery, if that makes sense.
Mm-hmm. It probably still should be looked at, because the way it's happening now is often problematic. So, but I realize it might not be doable in this, rollout.
Yeah, definitely. Please feel free to keep bringing it up. Like you said, probably might be difficult to do anything about at the moment, but something that maybe in the future we can look at again. Well, I think we're at time. So really, again, thanks for very thoughtful commentary again. These are really helpful things. Keep pushing us on, asking about, and we'll expect you to continue to do so, both in this next phase where we are preparing for launch and finalizing details, also in the post-launch phase where we'll need to make refinements and improvements over time. So thank you all.
Thanks,
Thanks,
everyone.
everyone.